Good afternoon and welcome everyone to our online information and support session. My name is Kathleen Helgeson and I'm the coordinator of the Patient and Family Resource Center. The needs of someone with advanced cancer are uniquely challenging for both the patient and their families. Today we have an opportunity to support people in this journey by bringing together 4 presenters who each have a valuable perspective on this topic. However, we also recognize that not all parts of this discussion may be relevant for you. We are very pleased to offer this session with the generous funding support from the Cancer Care Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, traditional land of the Anishinaabe, Cree, Ojibwe, and Dene people, as well as the homeland of the Métis Nation. It's important for us to foster inclusion and reconciliation and encourage others to do the same. Before we continue, there are a few basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your video are turned off. If you have a question at any time during the presentation, just click on the Q&A icon on your screen and type your question. You can also choose to ask that question anonymously by checking the Send Anonymously box before you click on the blue arrow to send. My coworker, Ali, is also here off screen and will be helping manage your questions as they come in. If you have a technical concern, you can also ask Ellie in the Q&A and she will answer your question privately and try to assist you. It's my pleasure to now introduce our first guest, Stephanie Lalonde. Stephanie has over a decade of experience in community-based programs and has been a clinical nurse specialist at Cancer Care for 6 years, initially working on quality of life in advanced pancreatic cancer and now working on the early integration of symptom management in advanced cancers. Stephanie also has a strong background in research, education, and leadership to accompany her clinical work. Welcome, Stephanie. I'm just inviting her to come back to the screen. There she is.
Yes. Hello. Thank you very much, Kathleen.
Thank you for joining us. So, Stephanie, I did want to have this rather frank discussion with you because I found in our resource center, we had a lot of literature using various terms, and it's something that I was a little bit confused about when I first started at Cancer Care. And there's terms like advanced cancer, palliative care, hospice care, staging, metastatic cancer, terminal illness. And I just wanted to, maybe talk to you a little bit about clarifying these terms and what they mean.
Yes, thank you. There are many different terms used in advanced cancer. Advanced cancer is more of our general umbrella term when we're describing a late stage cancer or a cancer that's unlikely to be cured. So while we use that umbrella term, there are many other terms, as you mentioned, that are sometimes used interchangeably with advanced cancers. So I'm just going to share a little slide here for you, actually. Now, maybe I won't. That'd be all right. That's fine. We'll just go on like
sure?
this.
Yeah, or you can share you're sharing your screen.
I don't know why that option doesn't seem to be available to,
Oh, could just be that your Zoom screen is a little bit minimized, so you might want to just open your screen. There we go. We've got it, Stephanie.
Perfect. Wonderful. Thank you. So as I mentioned, advanced cancer is really the term that we use to describe a cancer that is unlikely to be cured. That's not necessarily the case, though, for every time that we use all of these terms. So when a cure is unlikely, in that case, our focus of care really shifts from cure itself to living well, and it incorporates physical, emotional, and practical supports related to that for the best possible outcome. Like I said, the advanced cancer can sometimes also describe other terms, and you may have heard things like late stage cancer or stage 4 cancer or metastatic cancer. There are multiple terms out there that are used, and they can be used differently in different kinds of cancers. There's no real one size fits all definition. And while many of the terms overlap with each other, actually, they don't always mean the same thing. So while for most, this may mean focusing on staying as healthy and feeling as well as possible for as long as we can, for others, it might mean that the cancer will be managed more as a chronic illness. So when you need information that is specific to your cancer, it's always best to speak with your oncologist. Now,
go ahead,
sorry,
Stephanie.
I was just going to say, some of the other terms frequently used, as I mentioned, are metastatic cancer. And that in particular means that the cancer has spread to more distant parts of your body, as opposed to being close or locally advanced cancer, which is nearby to where it started. So when it's spread further away from that, it's metastatic, also sometimes called stage 4, or sometimes called terminal cancer, as stage 4 is the highest possible stage. And while it may most frequently be the case that a metastatic cancer cannot be cured, it's not necessarily the case for all metastatic cancers. So again, it's very specific to you. It's very specific to your diagnosis and should definitely be discussed with your oncologist.
So just to clarify then, and there are people that are diagnosed with stage 3 and stage 4 cancers that live well, like many years after their diagnosis, and with certain treatments may not be cured, but are certainly not showing signs of their cancer. Is that right? And would they still be considered an advanced cancer?
So that's very true. When something is stage 3 or stage 4, again, depending on the type of cancer and the treatments available for that cancer, we certainly can have people live for extended periods of time. And it doesn't necessarily mean that, that the cancer is progressing rapidly. So it's, again, very individual to the cancer you have, and a really, really important discussion to have with your oncologist to open that up. When you have questions like that, they're very, very important questions to get some clear answers to. So again, I would absolutely encourage everyone to bring that up as they're able in any one of their oncology appointments.
So now you mentioned about metastatic cancer when it spreads. What about when a cancer has been treated and then returns to the same place that it was, where it was the primary cancer? Would that be considered an advanced cancer at that point, or is that just a return of the cancer?
Okay, thank you for asking. I will share again. So when a cancer returns, can you see that properly? I just wanted to make sure.
Yeah.
Yes, that's fine. So when a cancer returns, it can come back, in the same spot or even sometimes a different part of the body as the original cancer. And often when it comes back, it's harder to treat because it may have become more resistant to the therapies that we had used to treat it earlier. Now, recurrent cancer is not always incurable, and that will depend on, again, what kind of cancer it is and perhaps whether it's close to where the original cancer site was or if it's maybe further away in the body, like metastatic disease. And I think it's always important for us to keep in mind that when we don't have treatments to cure the cancer, we can sometimes use treatments to help shrink the tumor or maybe slow the growth of the tumor or to relieve symptoms caused by the tumor. And when a treatment that we're using is intended to cure the cancer, of course, we call it a curative intent treatment. And when it's actually intended to either just shrink the tumor, but we're not able to get rid of it, or slow its growth, or simply to manage the symptoms from the tumor, we actually call it a palliative intent treatment. And if that's all right, while we're on the topic, I would actually like to just share a little bit more about some of the terminology around that as well.
Yeah, please do.
Wonderful. Good, good. So lots of people hear the word palliative, and right away think of end of life. And I think that's a very culturally responsive kind of thought, as that's how we have, generally speaking, used that term in the past. So now, while palliative care or palliative approach should certainly be available to people who are in end of life, it doesn't mean end of life. The word palliative actually means to alleviate suffering. And we can do this in many ways. According to our World Health Organization, this kind of care, this palliative care, should actually be initiated all the way at the time of diagnosis, which is when some people are feeling quite well. So it's important for us to clarify some of those terms. So again, palliative, meaning expert symptom management to support a good quality of life. And we all want a good quality of life. So that's something that we would start even right at the time of diagnosis. And it, of course, goes all the way up to and includes end of life. But we're starting that at a much, much earlier phase these days. So as you can see in this little chart here, we've got our disease management and we've got our palliative care, and there's really quite a large overlap in there. And it has to do with that symptom management and making sure that we're well supported. And the other term that you might hear or see in some of the resources that you find in the resource center there would be hospice care. And again, that's also different from palliative care. And hospice care would really be more directed towards end of life care. So seeing a bit of a separation in the terminology between palliative care and hospice care being two different things.
So you mentioned that it's more common practice then now to talk about palliative care early on in diagnosis, as opposed to thinking of it as a late stage discussion.
Yes, absolutely. Much, much earlier. So certainly at one point in time, that was something that was discussed only when, there were no other treatment options available. However, at this time, we're actually instituting a palliative approach to care, right, like I said, at the time of diagnosis, but also at the same time as disease modifying treatments or things like radiation or chemotherapy. So it's not that we do all of one until we have none left and then we do some of the other. It's making sure that even during the time of treatment with those therapies, we're still supporting a good quality of life and good symptom management.
So somebody with stage 3 or 4 cancer can still be a candidate for chemotherapy, radiation, or immunotherapy?
Yes, absolutely. Absolutely. As long as there is a benefit in modifying disease, or like I said, controlling it somewhat, slowing it down somewhat, sometimes even shrinking it somewhat, as long as there is a benefit to that, and those benefits outweigh the risks or the harms, then that would be a perfectly appropriate option, even in a metastatic or stage 4 or stage 3 cancer. Absolutely.
Okay, great. Good to know. And is there a possibility too that while somebody's being treated and they maybe be treated in a certain way for a number of years, that other treatments could become available that may also assist that person? Is that a possibility too?
Absolutely, of course. There are new things coming out, and certainly clinical trials are another option that are out there. Generally speaking, those are new treatments that have not necessarily been established as a standard of care, but that are an option to look into. Usually, they're pretty finicky in who they would accept onto trial. Either they're looking at just something very specific, a certain genetic variant of something, or people with a certain functional capacity, people who haven't tried certain medications before. So there is usually quite a big long list to look through to see if somebody is eligible for a clinical trial.
So how are the supports and needs for different for somebody that is diagnosed with an advanced cancer?
Sure, so I will go back to sharing my screen. And there we are. So some of the supportive needs that are specific to an advanced cancer is a really good understanding of your diagnosis and its related prognosis. Because it's so individual to each person, depending on treatments that they've received before, whether something is locally advanced or if it's metastatic, as discussed earlier, and really having a good understanding of what that is and what that means to you is very, very important in advanced cancer. When people find out that they have, a life-limiting illness, having a good understanding of what to expect is essential. A lot of the uncertainty around that is some of the most difficult piece of it. And so making sure that everybody actually knows what's going on is a way to be able to sometimes move forward in that. So that's one very important piece. The other would be symptom management. So of course, if a disease has progressed beyond just one little area, it's often causing extra symptoms. So depending on where the cancer is, those symptoms could be very different. But generally speaking, maybe we would see some fatigue, see some nausea, see some pain, things like that. And so being able to address those in a way that provides the absolute best functional capacity so that people are able to go about, as much of their day as normally as possible. So that's a very important need, that those symptoms are expertly managed and people aren't thinking that they'll have to just kind of stick through it and have that as a part of their day all the time. We really want to manage symptoms to the point where people are able to, like I said, go throughout their day as normally as possible. So along those needs, of course, then is medication management. And certainly consideration of complementary therapies. So we often will use medications to help with the symptom management. And sometimes we actually find that because we're adding on some new medications, that we've got too many on board. I don't think there are terribly many out there who are keen to be taking a whole bunch of different medications. So it's nice, well, it's actually essential to have a look at all of the medications that are being used and to start picking and choosing what is really needed here, what is going to benefit us in the short term, what is really meant for much, much longer term use, and trying to get down to a much more manageable pill burden. And then complementary therapies. There's all kinds of things that are also used that are not necessarily a prescribed medication. So the use of massage therapy is sometimes offered, or physiotherapy certainly can be offered, and many other different modalities that we can use as either an alternative or as a supplement to the medications that people use. Then, of course, we need some more coping supports. It's not easy for anybody to have a diagnosis of an advanced cancer, and neither for their family or loved ones. So providing some extra supports to help them cope is needed. The other two things listed on here are also quite important in the setting of advanced cancer. One of them is called advanced care planning. Now that is just what it sounds like, planning for your care in advance. So when we're doing advanced care planning, that's really just letting your healthcare providers know what you would want for your own medical care if for whatever reason you weren't able to tell us. And that really actually goes for everybody. We all need to have some type of advanced care plan and have conversations with those around us who might be able to speak up for us and advocate for us. Now, the other important piece here is a goals of care conversation. So that really is a very individual specific. It's about us as providers learning about who you are as an individual in order for us to learn what your priorities are, what your needs are, and what the focus that you want to take in your treatment. So having an in-depth conversation, a good understanding of what's important to you is part of that goals of care conversation.
Stephanie, just a comment from one of the viewers that said that they felt that spiritual work and complementary treatment therapies was really important. And thank you for touching on that. I believe Dr. Danek will probably talk a little bit about that as well in our conversation. Are there specific supports available through Cancer Care and the WRHA that we should know about for advanced cancer?
So Cancer Care itself has many embedded services for advanced cancer throughout the clinics. For instance, we have these advanced cancer booklets that can be taken home, and they're full of written information and further resources that you can go through. Oh, you have it. I have it too. I'm so glad to see that. But
and the advanced cancer one, about conversations. So
yeah. So those are in the clinics, and certainly is, like I said, written information for people to take home and to go through at their own pace. You know, it's not easy to get a big dump of a bunch of information. So this is something that not only can you take your own time to go through, but you can also share with others, right? You don't have 10 people coming to your appointments. So this is one way that you're able to share some of the issues surrounding advanced cancer with those around you. So one of the booklets is actually called The Emotional and Practical Aspects of Care. Another is about managing symptoms. And the third there is support for family and caregivers. And it's full of information and other resources, as well as some good discussion on how to cope with that.
And those are available on the website as well if people are looking on the website for that too. But let us know if you're interested in getting the hard copies.
Yes, we also, of course, offer psychosocial oncology referrals, and I think Cheryl will talk a little bit more about that today, but that would provide additional support for managing mental, emotional, practical, financial needs. And then here at Cancer Care, we also offer an early palliative care program that at the moment is only available to advanced pancreatic cancer patients, but certainly we hope in the future to be able to offer that to other advanced cancers in the future.
So the WRHA program of palliative care, is that something how does that work, a referral to that if somebody is needing a referral to that program?
Yes, so they offer lots of wonderful supports. I would say that when we're looking at, that palliative care and hospice care kind of continuum, they certainly do provide services more towards the hospice end of care. Ideally, if we had all the resources and supports that we would like, they would be offering much sooner than that. However, they do offer services where the nurse comes to your home, where healthcare aides will also come to your home to support more physical needs. They have social workers as well to help with some of the coping, and physicians as well to really provide expert symptom management. They do have palliative care units, so there's sometimes hospital beds available for more in-depth symptom management. And there's 2 hospices in Winnipeg as well. So and medication coverage. That's right. There's also medication coverage provided. And depending on where you are in the province, there's different resources available in each area. So that was specifically the Winnipeg Regional Health Authority, but the other health authorities certainly have other resources as well.
Thank you. So what have you, in your experience, noticed as being some of the biggest obstacles that people face when accessing supports and resources, and how can some of those challenges be addressed?
Well, I think I hinted to that a little bit. Sometimes we certainly would love to have more palliative care involvement and support much earlier on in disease trajectory. But again, I think that's going to be less of a specific and dedicated program, being able to offer more human resources and start working more with the resources that we have. So integrating more of a palliative approach to care within cancer care here. So with our oncologists, with our nurses, and certainly this is already happening, in many areas. And then our cancer care also has the pain and symptom management team as well. So, and that's what Dr. Danek is going to speak to shortly. So I will let him go ahead with that.
Thank you for that segue. So thank you, Stephanie. And Stephanie will be here right up until the end of the session. So if you have any questions that you have, we'd like to ask her, then she'll be joining us again at the end. Thank you, Stephanie, very much.
Thank you.
So I'll invite Dr. Danek to join us now. And Dr. Paul Danek is a medical oncologist and palliative medicine consultant with Cancer Care Manitoba and the Winnipeg Regional Palliative Care Program. He's also an assistant professor in the College of Medicine at the University of Manitoba. Dr. Danek has served with several national organizations and is active in the education of medical professionals. He has ongoing research interests in palliative medicine, including the use of medical cannabis in patients with cancer. Welcome, Dr. Danek.
Hello.
Hi, thank you for joining us.
All right. I'm just going to move forward and do the presentation.
Wonderful.
Perfect. I'll just share my screen here. Excellent. Okay. So everybody should see the title page, the Cancer Pain Assessment and Management. This is for patients who are living with advanced cancer. Come on. There we go. And what I've done is I've put together a few learning objectives for you to kind of keep an eye on as we continue through this presentation, knowing how to work with your cancer team to both diagnose and then to treat cancer pain, learning about different sorts of medications, and there's not only drug therapies, but there are non-drug therapies that we should consider as we move forward in treating pain here. So pain is a frequent problem due to cancer. And it's not only due to the illness, but it may be due to other things as well. Let's say surgery, radiation, chemotherapy sometimes can cause pain, and we have to be attentive to that and treat that appropriately. It is that type of symptom that patients and families may fear the most. There's been a number of studies who have asked patients about this, and they do feel that this is a fearful problem, something that they feel that may not be treated right. And so there's a certain uncertainty about it as they go forward. And certainly even now, when we have lots of good treatments, we have good ways of assessing that. We have healthcare providers that are not necessarily looking for pain or are worried about using medications to treat pain. They worry about addiction. And that becomes a barrier to patients who are wanting to get good pain management. So just as I said, pain is a major symptom. When we take a look at various studies, we see that it accounts for about 80 to 90% of the symptoms, or it's seen in 80 to 90% of patients who have cancers. And certainly it was thought that pain only was due to the tumor, the cancer itself invading into another organ, causing pain. However, we know that it's much more complex than that. There are neurobiological, there are molecular mechanisms within the patient themselves. There's the involvement of various receptors. So within the nervous system, we see these changes. And there are kind of components of reaction of the body to these sorts of tumors, like inflammatory reactions, biochemical reactions, that we have to account for as we're treating cancer pain. When we're talking about types of pain or trying to categorize it, we can look at acute, so pain that comes on and is there for a very short time, or more chronic pain, pain that is there and continues to be a problem for 3 months or more. Much of cancer pain is of the chronic nature because of the fact that many cancers take a period of time to be treated, or they are more problematic, such as advanced cancers. You can have what's called nociceptive pain. In other words, we're alerting the receptors in our body to the fact that there is pain there, and these may be bones and muscles that have been affected. Bony pain is a type of nociceptive pain. Neuropathic pain is somewhat different. It involves the nerves or nervous structures, and it actually has a different feel, and that's why it's important to characterize this in a different way. And the same with visceral pain. If you've ever had constipation, or if you've ever had nausea, you'll know that the feelings that you're getting that way are different than if you have low back pain or if you stub your toe. So this is something that affects the organs inside. People describe these pains in different ways, and it's important for us to listen to patients and families, because this can help me not only characterize, but then to localize the cancer pain, and then to look at specific treatments to help that out. So it can be described as localized or generalized, sharp or achy, throbbing. It can migrate from one area of the body to another. It can become crampy. It can burn or tingle. It can shoot or stab. These are very typical sort of things when we're talking about neuropathic type pain, and especially that radiation of pain along nerve pathways. Some people will say that it starts in the back and goes right down the leg to my foot. We can also see some changes in the way that the body senses this. It changes in sensation as we get closer to trying to realize what it is, such as pain or not. So for instance, a light touch may be perceived as painful. That too means that there's probably some disordered reception involving a nerve or the central nervous system. We in the pain world, in the palliative care world, often talk about total pain. In other words, pain is not just comes from a single source, but there are a number of different contributors to it, if you will. So certainly the history, if you have a history of chronic pain, adding in cancer pain can cause more troubles. If there's emotions or psychosocial issues, there might be a contribution or a worsening of the pain. Certainly people who are depressed exhibit or tell us that the pain that they feel is worse than when they're not depressed. Patient and family, if there are unresolved issues, that sometimes can cause worsening of the pain as well. I'm not expecting you to understand everything that's being seen on the screen right now, but we often talk about these different domains of pain: the physical, the social, the spiritual, and the psychological. And because of that, it means that we also have to look at focusing in on some of these. Some of it might be medication, some of it might be non-medical or non-medication, and we'll explore this as we go forward. Probably the most important piece of information that I want from the patient, the family, is what's the history? What's going on here? I really want to know from you to tell me, what is the timing or the duration of pain? Is this a pain that just doesn't go away, or is it worse at certain times during the day? Is it something that's worse at night? Is it worse in the morning? These are important things for me to focus on to have a better idea of how to characterize it, treat it. Where is the location of the pain? Does it radiate or does it move from that place to a different area? Is it severe? Are we talking about a pain that you would rate as 9 on 10, 10 being the worst pain you've ever had? Or is it kind of moderate, let's say 3 or 4 out of 10, but it's still quite bothersome? We also want to know the quality of pain, and that's where those descriptors, the burning, the tingling, the sharp, the dull come into play. I also like to know what makes it worse, what makes it better over that, when whatever you use to try to make it better. Sometimes we find out that there are things that people have tried that we can add to rather than say, oh no, that doesn't work, let's try something different. And of course, the previous history, that of chronic pain or a family history of difficulties with pain, need to be looked at. I also want to know what sort of medications you're currently on and what sort of medications could be used to help out. I wouldn't want to use medications that have already caused you a lot of side effects. I'd be looking at something new or something different. In addition to that assessment, that history, I'd want to know a little bit more about the exam, the physical exam, show me where that area is. It wouldn't have to be head to toe unless the pain was in that region, but usually what we're looking at is, oh, there's pain in the belly, let's have a look, let's examine, let's see, oh, there's a big mass here. That could be the source of the pain. And then we can use imaging to further pinpoint where these issues might be, to see if there are other modalities that we can use in addition to, let's say, some medication. And then I like to do some blood testing. I'd like to know what your kidney is doing, what your liver is doing, because it's really important when I'm using certain medications. They might need to be metabolized by the liver, cleared by the kidney. So I need healthy function to get that done. And of course, ruling out infection. Many times in some situations, some cancers, treating the infection is the best way to treat pain. We're often using a tool to help you describe the pain to us. A compass is something that has been used in Cancer Care Manitoba for quite some time. And now we are using this through the Nuna app. So many of you have been asked by your team to join up to Nuna. And using this, we can get a better sense of where things are at with your pain. We can get an intensity measurement. We also can kind of set it up against the other symptoms that we may be seeing, which again may have some contribution to the way pain is determined or is sensed. Again, this is kind of a busy slide, but really what we're showing here is that there are many, many treatments that are available to help out with pain. All of these have a role to play in cancer pain. So in terms of physical, in other words, things that we can do, patients can do, as well as getting someone such as a physiotherapist or an occupational therapist to help out. Caregivers can certainly help out with this sort of thing as well. Exercise, we have found, helps out with cancer treatment. It also can make pain treatment a little bit easier. And certainly we can't expect everyone to be active this way because it depends on their functional state. There are some people that are quite active, so they can partake in normal activities such as walking or cycling. Physiotherapy is really good because it can help to describe different activities that can focus in on pain, or we can help to strengthen muscles that will help to reduce the pain, let's say a pain of a joint or a pain of some bones. Other sort of physical activities that may be have less impact, things like aquascience or aqua fitness, conditioning exercises, massage, as Stephanie described. I put a question mark because for Pilates, because you would probably want to have more low impact rather than high impact Pilates. If you are someone who doesn't have a whole lot of energy, or you're not able to be as active due to things associated with the cancer, chemotherapy, we can look at passive stretching. We can look at passive activities. We can look at transcutaneous electric nerve stimulation, TENS, as they say here. Yoga is very good. Yoga does not need much in the way of activity. You just have to be able to do some of those movements. And even participating in yoga and only doing some of the movements that you can do may be helpful or moving forward in helping get that pain under control. In terms of psychosocial or psychological emotional type of input, there are many different modalities, and I know that Stephanie mentioned them, and we'll be talking to Crystal about some of that as we go along. Counseling services, the cognitive behavioral therapy, hypnosis or distraction is going to be important here. Psychotherapy can be really key to helping people get to the point where they can help with their pain. And as people get towards the end of their lives, Dr. Harvey Chochinov has developed what we call dignity therapy or person-affirming therapy, and that can be really helpful in terms of reducing the stress and in time, reducing the pain that patients are feeling. Certainly, I think most of us know that when you have pain, we take a pill. And what are the types of pain pills that we can have? Well, there are lots around, and we'll work on those in just a second here. And you can see that there's a long list, and I don't have time today to go through every one of these, but you can see that some of things like the opioids, the anti-inflammatory medications, some of these are over the counter, some of these are prescription, and then there's a number of others, what we would call targeted therapies. So, although these are available to everybody, not everybody uses them. So acetaminophen, ibuprofen, naproxen, these are over-the-counter drugs. They can be very effective in getting a kind of a baseline or having a foundation for pain control. We often talk about a limit of 1 gram 3 times a day for most people who are taking acetaminophen. That's 2 extra strength 3 times a day. And the same with something like ibuprofen or naproxen. Naproxen is also known as Aleve. If you're using it, you want to make sure that you haven't had a sensitivity to it. What's your kidney function? This would be something that you would talk about with your team. We in Canada are very fortunate. We have a very wide choice of narcotics or opioid pain relievers. And you can see drugs such as codeine, which is fairly mild to as strong as methadone, fentanyl, sufentanil, and these can be used by most practitioners. Some, such as methadone, fentanyl, sufentanil, buprenorphine, do require a certain level of knowledge, and that's where I think that a lot of us specialists, pain specialists, are called upon to use these sort of medications. And these can be very powerful. They can also be very effective for patients as they deal with their cancer pain. Unfortunately, this whole family also has some adverse effects, and these are things that we need to remember as we're treating patients. Most of them cause some form of nausea. Sometimes there is this drowsiness that happens as we start the medication, and that will be reduced over a period of time as the patient develops tolerance to it. There are ways that we can help with these adverse effects. Sometimes we have too high a dose, or sometimes the pain has reduced because of the treatments, such as chemotherapy or radiation. We might have to switch different opioids. We might have to look at a different route of administration. So if oral is causing too much nausea, we might need to look at topical or some other way of getting the medication in. And of course, looking at trying to treat that adverse effect with constipation, especially if 90% of patients are going to have constipation with these opioids. Almost all of those will also be on some form of laxative. There are a number of what I call targeted therapies. These are therapies that are developed for other purposes, such as antidepressants, yet they have some benefit, and they've been shown to be beneficial in clinical trials for patients who have cancer-type pain. So drugs such as pregabalin, ketamine, venlafaxine, even the whole area of cannabinoids, especially the tetrahydrocannabinol, have been used in clinical trials and have been shown to be quite beneficial. These last couple of drugs, bisphosphonates, denosumab, these are drugs that have effects upon bone, and they can be very helpful in terms of reducing bone pain in patients who have advanced cancers that are involving bones. Again, living in Canada, we're really fortunate. We have access to cannabis, both as a recreational drug, if you will, also as a medical treatment. And the range of cannabis medications that you can get through a discussion with your team, with your physician, has been growing quite a bit over the years. In 2017, we really only had dried cannabis, maybe a few caps, but now we have a whole list of medications or infused foods, edibles that can be helpful for patients who are interested in using this as a additive to their core pain treatments. In terms of surgical or what we call interventional treatments, there are things, even something such as acupuncture could be listed under this area. One of the most effective treatments in this is radiation. So if a patient has a cancer that has affected the bone, the use of radiation can help reduce that pain. And radiation can be effective in up to 80 or 90% of patients, depending upon the location, the type of disease that we're talking about. But it can be really, really helpful. And I am constantly talking to my radiation colleagues about assisting in getting some of these pains under control. In addition to all of these interventions, we also have to monitor these, monitor patients, monitor people who are taking these medications or are involved in some of these activities, maybe having some form of intervention, surgical intervention. So often when I'm starting a medication, I will give the patient 3 to 4 days to trial it. And then one of the members of our team will be in touch with the patient, find out how things are going. We generally phone the patient to find out how things are, but we, because of COVID, we've also been able to use other modalities and it has worked very well. We are monitoring for those adverse effects as well. If you're having lots of side effects and you're not taking the drug, you won't get that sort of benefit. So we are trying to be more aware and dealing with it or addressing the effects as we hear about them. NUNA is very important. If you're registered, that's great. Use the services available. If you haven't been registered yet, talk to your team because they will help get you registered. And NUNA just allows us to know where things are at. What are your symptoms? How intense are they? Is this something that we need to look at right now, or is it something that we can talk about at our next appointment? And just a reminder, there's an on-call medical oncologist accessible 24 hours a day. I and my colleagues take turns being on call. We're on call for the weekend. So if there are problems that arise, especially with pain, it's something that can be dealt with. You shouldn't sit on pain either because untreated pain becomes harder to treat if we wait too long. So just to sum up, it's a common symptom. It's something that we see in many patients who have cancer. Assessment is a really important step. I want to know what the pain is like. I want to characterize it so I can give you the best possible treatment. There are lots of different therapies out there. It's not just about here, take a pill. There's so many other things that we can do. And again, just as Stephanie said, we run pain and symptom management clinics. We have 4 or 5 every week. So I think it's important that if you feel that your pain is not being dealt with well, or you're not responding to, let's say, first-line agents, we'd be very happy to see you and to help out through our pain clinics. All right. Thank you very much for your attention.
Thank you, Dr. Danek. I love the Herman cartoons. Just a question about the pain management clinics. How does one get a referral, or can they self-refer to that?
Not self-refer, but we do accept referrals through, physicians both in cancer care and outside of cancer care. So if you feel more comfortable dealing with your family doctor, or let's say a family practitioner in oncology in your more rural site, absolutely, we would take that. I also know that sometimes we need to work with our nursing colleagues, such as Stephanie. Stephanie has seen many patients and she's referred them to us, so we're able to make that work. But we do require a referral so that the physician may be available, or maybe may be part of the treatment that we apply. Let's put it that way.
Great. So a few questions came in, and there was a couple that were relating kind of to that global understanding of pain that you talked about, the psychological aspects. But I think what I'll do is I'll leave them until the end after Cheryl presents and talks about the psychosocial aspects of advanced cancer. And then we'll bring you back on again at the end of the session so I can ask you these other questions.
Sure.
Okay, thank you, Dr. Danick.
No problem.
See you in a bit. Our next guest is the Executive Director of Palliative Manitoba. Jennifer Girk has also been a board member of the Canadian Hospice Palliative Care Association since 2019 and is currently the vice chair. She is an advocate for quality and equitable palliative care for everyone. Welcome, Jennifer. I hope I pronounced your last name properly.
Thank you, Kathleen, and thank you everybody for having me here this afternoon. And yes, you did pronounce my name correctly, so we are good. I'm just going to start sharing my screen as well because I do have a little bit of PowerPoint presentation to talk about Palliative Manitoba and what we offer.
So I should just clarify here, because this was something, again, that I was confused about, that Palliative Manitoba is different than Palliative Care Manitoba, right?
That is correct. Actually, we will often get confused with any of the palliative care programs throughout Manitoba. However, we are a separate organization, and I'll talk a little bit about that. So we were incorporated in 1983. So this year is actually our 40th anniversary year, and we have lots of events to celebrate that. As I indicated, we are a nonprofit charitable organization. And we provide programs and education to help ease the suffering of the dying, the bereaved, and their caregivers. Another really important thing that we do at Palliative Manitoba is to advocate for equitable access to palliative care in Manitoba.
Jennifer, is it possible to just expand your slide so it takes the full screen? We're just seeing kind of a divided format here.
Oh. I'm not sure if I can do that or not.
We had it. If not, it's okay. I know we had it up earlier when we were testing it, but this time it's just a bit of a different view.
Oh, that's unusual.
It's okay.
And I'm not technologically inclined to be able to figure out how to do this. So
it's no problem. We still have the screens. They're just a little bit smaller, but you could go ahead and we won't worry about it.
Okay, I love technology, man.
When it works.
Exactly. And we receive our funding through the Winnipeg Regional Health Authority in the form of a service purchase agreement. We're also a partnering agency within the United Way of Winnipeg, and we do a ton of fundraising to ensure that we can provide the support to individuals who are experiencing grief and to individuals who are dying. So one of the main programs that we run through Palliative Manitoba is our end-of-life visiting program. So people who are on this program are referred to the program through the Winnipeg Regional Health Authority Palliative Care Program. And so we have volunteer visitors supporting individuals who are living with a life-limiting illness in their home and as they move through the healthcare system. So for example, if we have a volunteer who is providing one-to-one support in a person's home, and that person needs to be in hospital, our volunteer can also go and visit them while they're in that hospital. They have that hospital stay as well. And so our volunteers really provide a compassionate presence to the individuals that they are supporting. They also can provide respite for family caregivers. So for example, if we have a volunteer who is going into an individual's home and providing support, family members who are also living in that home may take that opportunity to, do some self-care, go run errands, or take a break. Our volunteers are trained, I should say. They take a 10-week compassionate care course that we offer, and they also go through several different criminal record checks, child and adult abuse registry checks too. So we vet our volunteers very intensely before we have them start volunteering with us. We also have our telephone bereavement support program. So this is basically one-to-one telephone support, as it sounds, by trained volunteers for grieving individuals throughout Manitoba. And this just really offers a safe environment to individuals where they can speak openly about the grief that they're experiencing. We know that grief is universal. We know that everybody experiences grief differently. And so our volunteers are trained to be able to respond compassionately over the phone to allow individuals to express themselves without being judged. And so people who are grieving can expect to receive a weekly call from a trained volunteer once a match has been made. And each of those calls can be up to 1 hour in length, and a match can last for anywhere between 12 and 15 months. Sometimes it's shorter than that 12 to 15 month period. It's very individualized service. And so we really want to support the individual that is grieving. Now, I know a lot of people will refer to this program as counseling or therapy, and it may be a therapeutic program for individuals, but it is definitely, it's not therapy and it's not counseling. It is more about a peer support for individuals who are grieving. It's a compassionate presence over the phone, and our volunteers are really there to listen and provide support and hear your story of grief. Another thing that we offer are grief seminars. So we offer our grief seminars in partnership with Chapel Lawn Funeral Home, which is on the west end of Portage Avenue, Propo Funeral Chapel, which is just North Main downtown. And then we also offer them at Glen Eden Funeral Home in West St. Paul. And so what we do is we have experts in the field come to speak on topics associated with grief. So for example, during the holiday time in around November or December, we will often host grief seminars about talking about grief and the holidays, because we know how difficult grieving during the holidays can be. And we always have staff and volunteers available at the grief seminars to provide additional support, because we know even in an educational kind of a context that those emotions can come up, and having someone there to talk to that's trained in providing grief support is really important. And just, you know, to note, our seminars are free and open to the public. And if you are interested in learning about when our grief seminars are, we have all of that information available up on our website at palliativemanitoba.ca. And I have the last slide at the end too that provides some additional contact information. Some of you may be familiar with our memory tree, and the memory tree started in 1987. Oh, that's a long time ago. And it's really a special place to help ease the pain and ease the suffering of grief during the holiday season. So from late November to December 24th, the tree is located at St. Vital Center. It's a 20-foot tree. It's always in front of the bay in the mall. And cards are available there to write messages to loved ones who have died. And volunteers are available to provide support if needed. This is one of the things that we offer the community. It's also a way to acknowledge that we all experience grief and that we really don't necessarily need to hide it. So this is something that is very much out in the open. And in any given year, we have anywhere between 1,800 and 2,000 cards placed on the tree annually. And then in the spring, we have a ceremony. It's called Light the Memory Ceremony. And what we do is we very respectfully bless the cards and we burn them so that those messages that are written on the cards can be sent up to the ones that were meant to hear them. And, you know, that's my Reader's Digest condensed version of the support that we offer at Palliative Manitoba. And if anybody has any questions, I'm certainly going to be sticking around for the remainder of this session, but you can also contact our office at the above information.
Thank you, Jennifer. Thank you for the service that you provide as well. It's really important and valuable. So thank you for joining us today.
Absolutely, my pleasure.
So last but not least, our final guest, Cheryl Dizon-Renante, is this clinical lead of psychosocial oncology here at Cancer Care Manitoba. As a counselor, Cheryl has served patients and families affected for cancer for over 7 years, primarily within the breast and prostate disease site groups. Cheryl provides individual, couple, and group therapy, as well as information sessions. Thanks for joining us again today, Cheryl.
Hi there, Kathleen. Yes, so if it's okay with everybody, I'm just going to go right into my presentation as well, and we'll just share my slides. So maybe if you could give me a thumbs up, Kathleen, once you see them.
We're good.
I don't think they're the slide view though. How's that?
That's just with the other slides on the side. So I don't know if you
Oh.
want to change for your.
Yes, I'll try this again.
There we go. That's good.
Okay.
Yeah.
Great.
Mm.
So I am just super glad that Dr. Danick and Stephanie and Jennifer had mentioned the other realms of distress and pain through the psychological lens. And so what I wanted to be able to discuss today was the emotional impact of living with advanced cancer. And so that includes how you and your loved ones might feel, things that you can do to cope with these feelings, as well as the resources available to you under the umbrella of Cancer Care Manitoba. And there are plenty of things that you have access to. And so cancer and its treatment, they really affect people differently. So some experience distress and others don't, at least for a long time. And we want you to know that you have a right to supportive care throughout your illness. Sometimes people assume that feelings like anxiety will worsen as their cancer progresses, but we want you to know that with good supports in place and good care, distress can be managed. And so emotions may not disappear altogether because we're humans and that's how we're built, but there are certainly things that you can do to cope in healthy ways. So you'll see in front of you there that there's a range of emotions that we witness our clients experiencing and talking about. And what I want to pinpoint there right at the top is that hope is certainly an experience and an emotion that people tell us about all the time. So you can feel a sense of hope despite the cancer, and that what you hope for, though, can certainly change over time, because once you've been told that a cancer recovery or cure isn't possible, you can still hope for other things. And sometimes in counseling sessions, it takes a lot of verbal processing to kind of get through all of the emotions, and then hope tends to arise. And so some of the things we encourage in sessions is to plan your days as you've always done before. Don't stop doing the things that you love just because cancer it has been diagnosed for you. Find small things in life to look forward to every day. You can set dates and events and milestones and celebrations to look forward to as well. And just look for those reasons, big and small, to hope. What also comes out when we hear lovely stories from folks is a sense of inner strength. So people with cancer, even though they say, you know, I'm called survivor all the time, or I'm so strong, but I really don't identify with that. We hear a lot of dialogue as such, but we also eventually, it's so neat, get to a point where people go, oh, but you know, I did get through that hard time and it passed. They discover strengths that they didn't know that they had. So, for example, you may have felt overwhelmed when you first learned that there wasn't a cure for the cancer, and maybe you're finding things difficult and it's hard to cope right now, but those feelings of helplessness may certainly change, and you can find physical and emotional reserves that you didn't know that you had. And I learned so much from the people that I have the privilege of working with every day, and they show me that. With sadness, it's normal, right? For everybody to be sad. You may not have the energy or not want to eat, and that can certainly contribute to sadness. And around these parts, we always say that tears are healing, and it's okay to cry. and to express sadness in a way that is meaningful for you. You don't have to be upbeat all the time or pretend to be cheerful in front of other people, because nobody can pretend to be okay 100% of the time, 7 days a week, 24/7. And really, pretending to be okay can even have the detrimental effect of creating barriers between you and your loved ones, because real talk maybe isn't happening. So we encourage folks not to hold their feelings in, release it in a way that comes naturally for you. Sometimes it's counseling and sometimes it's not. Some people say that speaking to a professional is different than speaking to a loved one, because you don't have to edit when you talk to somebody who isn't directly involved with family and with the personal life. Again, it doesn't have to be counseling, but we talk about other ways of coping, like creativity, accessing hobbies or musical instruments that you used to love, but you haven't had the time. Exercise, that's been discussed. That's another way to reduce and release tension within the body. Grieving, sometimes, it takes some processing to grieve things like how your body used to be. So the loss of being able to do some things, grieving the life that you thought you'd have at this point. And so again, just processing some of those things that have happened and experiences can lead to, once you weed through that pain, a sense of hope and a sense of inner strength, because there's certainly no way over or around pain. There's emotional pain. You kind of have to go through it. Anger, we certainly hear a lot about that, and it kind of gets a bad rap, because anger is a normal and healthy emotion to feel when one feels that things are out of control or uncertain. It tells us that something is important and that there needs to be change. It's just that we have to learn how to transform and cope with that anger rather than transmit it in an unhealthy way. And so sometimes in counseling, that can certainly be processed out loud. Stress, of course, there's a lot going on for you and your loved ones. So stress is a very common experience that people feel, fear and worry. Sometimes patients or family members worry that talking about their fears and worries will make things worse or make things feel worse, but we certainly see that that isn't true most of the time. Thinking about getting sicker or things that can happen, thinking about it and talking about it, again, that processing will eventually lead to thinking about more realistic outcomes. And so that's a little bit of that cognitive behavioral therapy that was discussed earlier, more realistic thinking and reframing of thoughts that tend to follow us around and cause anxiety. And then there are things like guilt and regret that people experience and talk about. Some people look backwards and maybe beat themselves up over choices that they've made related to cancer and not. And again, there's something about naming it to tame it, naming these emotions, naming the experiences that do tend to tame that sense of emotional and mental pain. And lonely, we do hear about that as well. So even though folks might be surrounded by a community of loved ones, family and friends, they may feel lonely some of the time, and that's normal. So I really wanted to take some time to validate some of the things that you might be experiencing today, but certainly don't take it from me. These are reflections from patients that we've heard of. So for example, I have good days and bad days, but I try to let there be more good ones than bad and focus on things in my life that I can control. I just do the best I can, enjoying family, friends, and the little things in life. Another theme that we hear about, I have people around all day, but there's nothing worse than waking up alone and upset at 3 a.m. in a quiet and dark room. And again, that's an example of naming what is going on for you in order to problem solve and process and think of alternatives. Another reflection, I know my friends try to understand, but they just don't get it. I can't even begin to explain to them how I feel or what's going on. It's not their fault. It's just hard. And so research tells us that these are things that can happen for the person diagnosed, but also family members and loved ones can also experience these things just as much, if not more, so than the person diagnosed, or maybe it's just in a different way. And so how to cope. We talk about two different categories of coping in psychosocial in our field, and that is problem-based coping. So just getting some information, seeking help, advocating for self, identifying what the problems are and finding solutions, that can go a long way in terms of coping. And we always encourage folks to communicate with their medical team, their family members, collaborate with everybody, your support community, and advocate for yourself. And then there's the arena of emotion-focused coping, which we've been talking about for the last few minutes. And underlying everything, we always encourage people to treat yourself with kindness and compassion. We all have that little inner critic within us that we have to tame once in a while. And when we get to a formal counseling platform, for example, with a psychosocial counselor like myself, we reframe some of those critical thoughts, connecting with others, acknowledging feelings that arise without becoming too absorbed in them or not staying there in that pit. So that is another way that we encourage folks to cope, is processing. Soothing of self when feelings are difficult. Again, it doesn't have to be through formal counseling channels, but in engaging in things that you enjoy, not staying still. Accessing activities that, again, you used to enjoy. We say a lot, follow the plan, not the feeling. So if your plan is to take a walk at 6 p.m. because you know that it is good for you, but at 5:55 you don't feel like it, follow the plan, not the feeling, and take those steps to go for that walk and take really good care of yourself. And just know that these feelings are likely going to change over time. An anxiety rating of 8 out of 10 will likely not be an 8 out of 10 consistently 24/7, 7 days a week. Things tend to settle, and that's just how humans are made up. And so some more strategies, just hitting home some really important ones for you: staying connected, keeping a routine, engaging in those enjoyable activities, get active, get creative, get focused on what matters to you most. A lot of people in counseling weed through some of the things that are in their life that are heavy or negative, and they make decisions to maybe put aside or get rid of relationships or burdens that don't need to be theirs. And so counseling and professional support, of course, is free of charge. Support groups are also available to people diagnosed with cancer that are professionally led, as well as they're also available to caregivers and family members, certain select ones, so that you can get support as well. And so other things under our umbrella of support are the Resource Center, where Kathleen is sitting right now, a whole lot of information and books available to you. We have dietitians and physiotherapy, webinar presentations such as this one. And I wanted to quickly plug that our next patient and family conference is going to be set for this fall, I believe. Oh goodness, I'm guessing here
November.
now, probably. Thank you, Kathleen. I knew you'd know. So that's a Friday evening and all day Saturday where we spend together and talk about valuable topics such as these. There is our Winnipeg main line. If you want to quickly jot that down. If you don't have a pen, no worries. Go to the Cancer Care Manitoba homepage and you'll find our Navigator newsletter. It lists all of our contact information and all of our support groups. So please don't hesitate to reach out. And
Wow.
so with that, Kathleen, how do I stop sharing? Okay.
Oh, yeah, there we go. Yeah, thank you, Cheryl. I'll get you to remain on the screen because I do have a couple of questions for you, and invite the other presenters to come back on as well. So we do have a few questions. A couple of them are related to the psychological component of pain and assessment. Somebody asked if there was a psychologist or psychiatrist at Cancer Care that assesses patients, and is there an offering of spiritual care?
That's a great question for whoever asked it. And so on our team, we do have a team in Winnipeg and across the province. We are psychotherapists, social workers, psychiatric nurses. However, under our assessment, if we find that referral to psychiatry is appropriate, then we work with your oncologist and clinic nurse to have that referral done. Spiritual resources under our umbrella, that tends to be woven into some of our counseling sessions, and people feel that they can sort of access spiritual / existential issues and topics with us. However, if there is a sense for a real spiritual specialist, then we refer out to the community and the resources that are available there.
Thank you, Cheryl. So I'd like to invite Jennifer and Dr. Danek and Stephanie to come back onto the screen as well. So I do have some more questions. Somebody asked about the complementary therapies like yoga and massage and qigong and acupuncture, whether there's ways of getting financial support to participate in these, because they're not all offered through CCNB. So these have been, a lot of these things have been noted as being very helpful, and yet not everyone has access to them or coverage for them. So any thoughts or any ideas about that?
Certainly some of the third-party insurance programs, employee assistance programs may be able to cover some of those. Unfortunately, no, the way Cancer Care Manitoba is funded, they are shared health is mostly focused on what's available at this time. They haven't started to look at other complementary therapies. However, there is more work towards something called integrative oncology. So in other words, not only looking at chemotherapy, radiation, surgery, immunotherapy, but looking at those other sorts of areas, the supportive or complementary areas that can be really helpful for patients. Although that isn't covered at this time, we do have access to a variety of practitioners within the city. So I would encourage people to look into that.
Thank you. Cheryl, did you want to comment about the programs that are offered through psychosocial oncology?
Absolutely. So there are, though, some creative programs that we have been able to offer, such as recently a creative writing program. We've had an expressive arts program that's been available for folks that where the talk therapy doesn't appeal. And a quick plug, Kathleen, for the yoga program that is available at the Wellness Center at Seven Oaks. So we do have one out of that list that the questioner asked about.
Thank you. These are a little bit more specific questions, and we may not be able to answer them, but you might have some suggestions about how the person can go about finding the answer. Somebody asked about how long after chemotherapy and radiation would one start to feel better in terms of pain. So maybe Dr. Danek, if you wanted to weigh in on that.
I would say it depends. If the pain is due to the cancer, then you would hope that after the treatments are pretty much done, then they would start to feel better. If it's due to the treatment, so radiation and chemotherapy can result in some damage to nerves. Sometimes that takes quite a bit longer to resolve. It may take as long as 3 years for chemo-induced peripheral neuropathy to resolve. Sometimes we need to look at some sort of intervention, such as acupuncture, medication, other types of physiotherapy or occupational therapies.
Okay, good to know. I didn't realize that peripheral neuropathy can last that long, up to 3 years or something. Yeah, okay, it's a long time. Somebody asked a general question, and anyone can answer this. How do I know who my clinic team is at Cancer Care, and how do I contact them? Would that be a question for nurse navigation, or is there a more direct way of finding that information out? Anything?
Well, I think that I would just add that if you have a medical oncologist or a surgical oncologist, some doctor that you have been treated by, then certainly that would be the first place to reach out. If you perhaps are here today and you haven't yet connected with a physician here at Cancer Care, then certainly we could either have we could reach out to the referral office, or if necessary, depending on where you're at this moment, could also perhaps reach out to our navigation services, as you mentioned. And if you could put that up in the
chat, I'll
chat
get
for everyone,
Ally
that would be
to-
perfect.
that number. You got that? Yeah, Ally will put that into the chat, the number, the Winnipeg number, as well as our number. If you want to call, if you're outside of Winnipeg, we can give you the regional numbers for the cancer navigation program as well. And a last question that's very specific. If glioblastoma returns, does a person go through surgery and back again resumes chemotherapy?
In general, it depends on, a lot of these answers depend because we don't know the very specific instances. But if a glioblastoma returns, there can be surgical debulking, another reduction in the size. Then they can be additional radiation if there was radiation left over, if the person maybe didn't receive radiation. And then, yes, chemotherapy, there are at least 1 or 2 different types of chemotherapies that can be offered. Again, if the patient is quite ill, it may be difficult to take that chemotherapy, but there are those other options. And again, I would refer back to the clinic team because they can give you even more details than me.
Thank you, Dr. Danek. There's a few minutes left. If there's any other questions from anyone in our audience, now's your chance to send that in the Q&A. And in the meantime, I just want to ask that that you take a moment to complete our evaluation at the end of this webinar, because we really appreciate your feedback. It helps us plan future webinars, as well as the patient and family conference that Cheryl plugged in her presentation. So that information is really important to us, and it just takes a few minutes. So if you could do that, that would be great. I'd like to once again thank all our presenters today for joining us and preparing such a valuable presentation. And if anyone has any further questions, feel free to reach out to us at the Patient Family Resource Center. And I know Ally has put that information in the chat, but I'll just give you the number as well. It's 204-787-4357, and we can direct you to other resources. So thank you once again, and take care for now, everyone.